So, hi everyone. As a part of our lecture series on contemporary implant dentistry, this is the video 2 of the series. Basically, in this chapter, we will be covering the radiographic assessment before and after implant surgery. We won't be talking about the planning part, but rather we will introduce you with the various modalities that we use for evaluation. We will talk about anatomical normal anatomy and the anatomical variation and certain pathology. So basically we are dividing the video in two parts, video 1 and video 2. So in video 1 we are discussing more of the modalities, objectives, little bit in detail about cone beam CT and certain artifacts. So that would be the part 1 of the video. In part 2, my colleague Dr. Akriti, she'll discuss about normal anatomy, pathology related to mandible, and any pathology related to maxilla. Alright, so let's start with the chapter. So now let's talk about the objectives. The objectives are divided in three phases. The phase 1 is pre-surgical, phase 2 post-surgery, and phase 3 after loading the implant with the prosthesis. So in the pre-surgical phase, what do we do? Evaluate for bone quantity and quality, proximity of any vital anatomic structure, or for any pathology. Okay, so in phase 2 what do? We have placed the implants and now we have to evaluate in the x-ray that how we have placed the implant. So you have placed the implant, you take an x-ray and you confirm that okay, this implant is placed properly. Phase 3 is after placement of implant, and when you have loaded the implant with the prosthesis, you do it periodically once in 6 months or once in 3 months to evaluate how the implant is keeping up, whether there is any loss of bone or not. So for all these cases we need imaging. So let's talk about pre-surgical imaging. So when it comes to pre-surgical imaging, we have different modalities. We can take an IOPAR, we can take an OPG, we can take medical CT, a cone beam CT, or we can do an MRI. So each of these modalities have their own advantages and disadvantages. They have their own indications and contraindications. So part 1 of this video is basically limited to this part only. Okay, so when we talk about pre-surgical imaging, the principle that we have to stick to is the basic principle, which is ALARA principle, as low as reasonably achievable principle. So whatever modality you use, the primary goal should be sticking to the ALARA principle. Alright, so next move on to the radiographic modalities used in oral implantology. As I said, the first one is periapical. radiograph. So the advantage is it is easily available in the clinic, cost effective it is, and the radiation exposure is quite less. However, there are certain disadvantages. First being is image distortion. So periapical radiographs have this issue of image magnification or shortening. So you must have read it in your final year that at certain angulation there is magnification, or if there is a certain deviation, there would be shortening of the image. Another disadvantage is it is a two-dimensional X-ray. So when we are placing planning for implant, we need a 3D image to do it, place it successfully. Two-dimensional images are not sufficient. Next disadvantage, poor identification of vital structure. Often in two-dimensional X-rays, it is difficult to differentiate between certain vital structures, especially if they have similar bone densities. So, what are the uses in oral implantology for IOPAR? As I said, for initial investigation, you get to know the bone height and all. You get to know about if there is any pathology or if there is any root stump left or not. And one important thing is for evaluation of peri-implant diseases, IOPAR has a certain advantage, which we will discuss in the upcoming section. So, next one is panoramic radiograph, the common OPG that we take. Again, this is a 2D modalities, so the disadvantages are similar to the one that we have in periapical radiograph, except that since it covers the entire maxilla, mandible, and the maxillary sinus, so it has a better FOV, and the evaluation is little bit easier on this. But again, it is susceptible to all sorts of image distortion, especially magnification issues with it, and you cannot take an you cannot do accurate measurements using an OPG. So the disadvantages, again, it is similar to that of IUPAR. Use in oral implantology. Earlier, it was considered to be a gold standard. People would use OPG and diagnostic casts to plan their surgery, and they have been doing it successfully, no doubt about it. But now, since we have other modalities, so I would say that OPG is no more the gold standard for radiographic evaluation. So, next is magnetic resonance and imaging. So, unlike your OPG and IOPA, this is a 3D modality. That means you get 3D images of these structures under evaluation. So, the advantages are it doesn't use any ionizing radiation. So, how other structures are going to appear on the MRI? So the cancellous bone will generally appear radio opaque or white because it contains fatty marrow. Metal restoration will not produce any scattering and thus will appear as black images. Therefore, MRI has been shown to be less prone to artifacts from dental restoration. So this is quite important when we talk about MRI. Another advantages are that if in a cone beam CT you are not able to identify the mental nerve, particularly because the mental nerve and the trabecular bone, they have the same density. If the density is similar, it would be difficult to identify on the conventional cone beam CT. So, in such cases, an MRI would be a better option to identify such structures, especially in the case you would see when the bone is osteoporotic. It is difficult to determine where the mental nerve is present, inferior alveolar nerve is present. So, in such cases, MRI would be a better option. So, you can read about the principles of it on your own. So, disadvantages. First thing I would say, it is a costly modality. Second, it is not useful in characterizing the bone mineralization. Okay. Now we come to cone beam computed tomography. So this is actually the gold standard if you are planning to do if you're planning to place implants. So in today's date, I would consider this as gold standard. So cone beam CT, it produces three-dimensional images of the structures in focus, and the advantages I would say is it doesn't use a lot of radiation. I mean, the radiation doses are quite less. The exposure time is quite less compared to the medical CT. So now let's see how does this CBCT work. So CBCT images are the result of data collected by numerous detectors and ionizing chambers in the CBCT unit. These data, which are collected by the detectors, correspond to a composite of the absorption characteristics of tissues and structures imaged. These information are then transformed into images, which is the raw data, that are reformatted into a voxel for evaluation and analysis. Now, what is this voxel? See, in a 2D image, when we see, suppose this is a 2D image. So, if we divide it into smaller elements, each of these square would represent a pixel. Okay. Suppose if this image was a 3D image. So in 3D image, the boxes, this individual boxes would not be a box, but rather it would be a cube. So this cube is voxel. So pixel and voxel, it is clear. Pixel, it is the smallest element in 2D image, and voxel, smallest element in 3D image. All these things are a bit technical, but we need not break our head so much to understand the technical part of it. So here you can see in this image, so this is the image, and if we divide it into pixel, and if we look into the individual pixel, so this one square is the pixel, whereas when we talk about voxel, it is a three-dimensional uh, element. Now, another thing that we come across in CBCT is Hounsfield unit. So, Hounsfield unit basically describes the density of the image. The range of these units ranges from minus 1000, that is of air, to 3000, which is of enamel. So, Hounsfield units are better visualized in the medical CT rather than in CBCT. But if you have asked for this DICOM file and you are evaluating it yourself, you will get a rough estimation of the Hounsfield unit in the imaging section. I will demonstrate this particular the planning part separately on a separate video, where I'll show you how do I plan and check for radio density and all, and where all to look for such numbers. So types of computer tomography. One is medical tomography. and the other one we discussed is the cone beam CT. So when we talk about the medical CT, it definitely has an advantages of giving more detailed pictures over the cone beam CT, but at the same time, the medical CT, they produce a lot of radiation. The patient has to go for higher exposure time, and in that way, it is not very prudent to ask a patient for a medical CT for a dental implant case. So I'll quickly show you the difference between medical CT and cone beam CT. So this is the medical CT. So the medical CT, the X-ray source will revolve around the object in a fashion that each revolution would produce one single slice. So continuously it will revolve around the object until it produces the desired image. So in this case, the radiation time is a lot more. So when we talk about the cone beam CT, the X-ray source will revolve just once, and in one revolution it will cover all the images, all the slices, and then these slices are transformed into a computerized form. All right, so that's what I told you, that the advantages of CBCT over medical CT. So now let's talk about certain terminologies related to. So this is the difference between a medical and cone beam CT. You can read it yourself. So let's talk about certain terminologies related to this computed tomography. So first thing is focal spot. So focal spot is the area of X-ray tube that emits the X-ray. So in general, the smaller the focal spot, the sharper would be the final image quality. Thus, a large source or large focal spot will result in image projections of shadows of the scanned area, which will result in blurring of the object. So the smaller the focal spot, the sharper the image and clearer the image. So the current CBCT units have a focal spots ranging from 0.15 to 0.7 millimeter. Now we talk about field of view. Field of view is, again, if you have a smaller field of view, you will have a better and clearer picture. If you have a larger field of view, you will have a certain blurring or distortions in the images. So the field of view could be small, medium, and large. Suppose you are doing an endo evaluation. So in such cases, the field of view would be small. But suppose you are placing a zygomatic implant, so the field of view would be medium to large. So now we move to the effective dose of cone beam computed tomography. So we have to know that at what is the certain dose at which the radiation is minimum. At the same time, we are getting the best possible quality of the image. So the effective dose is measured in microsieverts. Next, we move to the sensor detector type. So this sensor detector type, it is of two type: image intensifiers and flat panel detectors. So the flat panel detectors are costlier and have certain advantages. Voxel size. So Voxel size, when we talk about the voxel, we have already discussed what is voxel. So the smaller the voxel size, the greater the resolution and the quality. A voxel size of zero point 0.2 to zero point 0.3 millimeter is considered ideal because it allows for an equitable trade-off between image quality and the absorbed radiation dose. Now we move to spatial resolution. So normally CBCT scanners have voxel sizes of 0.075 to zero point 0.6, which are associated with higher spatial resolution than the medical grade scanner. So this is one of the advantages of CBCT over the another advantage of CBCT over the medical CT. However, decreased spatial resolution on CBCT image may result from the use of higher voxel. If we use the higher voxel size more than zero point 0.4 mm, then there would be decrease in the resolution and image clarity. So ideally, voxel sizes of more than zero point 0.3 mm is not recommended for implant planning. So these are the field of view. You can see the smaller field of view, the medium, and the larger field of view. Contrast resolution, it is defined as the ability to differentiate tissues of different radio densities. So basically, CBCT has an increased noise and image scatter compared with the medical CT. Smaller FOV may be used to minimize this noise and scatter. However, smaller FOVs are usually associated with slightly higher radiation doses. Bit depth, the quality of CBCT images is directly related to the number of shades of gray, which is bit depth. So CBCT units today, they produce up to 16-bit images, which corresponds to 2 to the power 16, which is 65,536 shades of gray. However, when we convert into computerized data, it becomes to 8 bits. That is 2 to the power 8. That means 256 shades of gray. So the monitor brightness and contrast may be then adjusted to display 8 bits per image to increase the quality of the image. So all these things I will show in the video demonstration while planning how do we adjust the contrast. So I use two software. One is provided by the Carestream and the other Horos. On both the softwares I'll show. Bone density. So the cone beam CT that differentiates the bone density, differentiating between the tissues that have physical densities of less than 1%. So if the bone densities are even less than 1%, the medical CT would be medical or cone beam CT would be able to differentiate it. The medical CT would be able to do it more effectively. So, in contrast, the conventional radiography, the OPG and IOPAR, requires a minimum of 10% of difference in physical density. So, unless two structures have a difference of 10 minimum 10%, then only they'll be able to differentiate it. So, as I said, when evaluating dental CBCT image in regard to bone density, a direct correlation accuracy of which is the accuracy of measurement does not exist compared with a medical CT. When we talk about those Hounsfield unit, that is more accurate with the medical CT and not with the cone beam CT. So this is the scanning technique. If you have a CBCT unit at your place, then you can read about it. Otherwise, it's not that important. So now let's talk about the artifacts. So first one is bone beam hardening. So this is one scenario where IOPAR has an advantage over the CBCT. Okay, in terms of the diagnostic approach. So, beam hardening occurs when X rays travel through the bone implant interface, resulting in more low energy photons being absorbed than high energy photons. And because of this, the image will have a compromised image quality. Suppose you are evaluating a peri-implantitis case. So in that case, it might happen that due to the titanium, if it absorbs a higher number of low energy photons, there would be radiolucency around the bone implant interface, and that might give you a false interpretation of a peri-implantitis. So in such cases, IOPAR is superior. See, this is the bone hardening artifact. So in this cone beam CT, we can see that this implant has some sort of peri-implant disease, but actually that is an artifact. Okay, so motion related artifacts. So if during the scan, if the patient moves or does swallowing movements, there would be motion related artifacts. Streaks, scatter artifacts. So if a patient has some sort of metallic restoration, so now understand these metallic restorations have higher atomic number and would definitely produce scattering. So if the field of view is a large view, these scatterings would be more evident, and if the FOV is small, the scattering would be less evident. So next is noise. So there are two types of noise associated with CBCT image. So first one is additive, the next one is photon count noise. Okay, so this is the scattering. These are the streaks that result from metal restoration. This is the noise. So now let's talk about bone dehiscence on 3D reformatted image. So some 3D images appear to have large voids or no bone present on the surface because the software averaging volume elements and the voids appear when the software attempts to reconstruct portion of the image covered by a thin layer of a bone. Suppose there is a case in suppose in the case of a maxillary anterior region, it usually happens. I will show you on the video when I do it. So what would happen that you might not be able to see the buccal bone when you are using when you are viewing the coronal section. That is the bone dehiscence phenomena that happens. So when you are actually doing the surgery in such cases, you would be able to appreciate okay, there is a bone present, but on the CBCT it looked like a dehiscence that the bone wasn't present. So it can happen. So slowly you are understanding that although this chapter doesn't seem that significant, how important it could be while planning. Now we'll come to incidental findings that you asked your patient to get a CBCT done for implant planning or endodontic evaluation, but during the course of this imaging, you discover some pathology which might be serious or it might not be that serious, but it can cause certain psychological discomfort to the patient. The patient might get scared of that pathology, or he might get embarrassed of that pathology. How do we keep ourselves safe from such incidental finding? First thing is when you notice certain finding, obtain radiologist report in written. So in that way you will be legally safe. So in such case, I would recommend that if you know any oral or head and neck radiologist, you send the report to them for a better evaluation. Now again, how to mitigate it? Use the smallest field of view as possible. But again, I will not recommend this. Whatever field of view is needed, you definitely ask for it. Normal radiographic anatomy. This part will be taken by Dr. Akriti. So for now, this is all for this particular lecture. So we'll just summarize what all we have read so far. So we talked about objectives, the different modalities, the cone beam CT, the artifacts, the incidental findings that we have, the advantages of a cone beam CT, and the cases where the cone beam CT have some certain limitations over the IOPAR. So, why this particular video was important? The first thing that, as a clinician, if you know that why a 3D modality would be beneficial for the patient, it would be easier for you to convince the patient to get a CBCT done. Usually, what happened that my patient would ask that a CT, they compare the cone beam CT to a medical CT. That okay, medical CT has a lot of radiation. So will a cone beam CT have a similar radiation? And that too for a single tooth. Why are you asking for so much radiation? So in such cases, you can definitely explain your patient that okay, this cone beam CT has a lot less radiation exposure. So that's all for today's lecture. Thank you.